For those who aren't familiar with pediatric chronic pain, I wanted to start with just a little epidemiology. Pain is incredibly common in childhood. There's a rate that's globally been reported of 44% of any type of weekly chronic pain. If we look at pain that's accompanied by moderate to severe disability, it occurs in 5 to 8% of young people. And the most common locations for pains during childhood are the head, the abdomen, and the limbs. But we know that multiple pain sites are very common during childhood. There's a peak rise in the incidence of chronic pain in mid-adolescence at ages 14 to 15 years. And for most pain conditions, girls have a greater prevalence of pain than boys. And importantly, this actually occurs post-puberty. There's been a lot of interest in understanding sex-dependent changes after puberty, and we know that a variety of biopsychosocial changes occur during adolescence and puberty that can impact pain risk. And just want to highlight this recent review article in Trends in Neurosciences that highlights both alterations that happen in clinical pain diagnoses post-puberty, but also in experimental pain responses in adolescence. So if we look specifically at orofacial pain, it's also quite common during childhood. The most common forms of orofacial pain are TMD, migraine, as well as dental pain and tooth pain. When we start talking about some evidence later on, I'm going to concentrate on psychological therapies, but I do want to highlight just the significant gap in clinical trials in orofacial pain in children of some common pain therapies. So there are large gaps. I've spent a lot of my career really trying to understand and evaluate how chronic pain impacts the daily lives of children and adolescents. We know that pain has a tremendous impact on academic and school functioning, ability to function in the school environment, on physical activities, as well as social functioning. Also can impact psychological functioning, in particular anxiety and depressive symptoms, and last, can contribute to sleep disturbance. It's important in pediatrics to highlight that pain also impacts parents and families. Caring for a child with chronic pain increases parental burden, can cause parental feelings of depression and anxiety, and a significant sense of isolation and lack of social support. There's also real financial burden from caring for a child with chronic pain in terms of both direct cost of care, but also the indirect cost of caregiving in terms of the parent's work and daily life. Indeed, pediatric chronic pain is costly. This is an analysis performed by Niels Grunwald, who's a colleague of mine in the lab, who looked at expenditures on pain-related conditions compared to other common childhood conditions, in this case, ADHD, asthma, and obesity. And as you can see in the red bar, expenditures for pain-related conditions are much higher than for other common childhood conditions. And as we'll see when I show you the risk for pain to continue later in life, is really the compounding of these costs across a lifetime that really is worrisome. I wanted to just bring attention to kind of the long-standing kind of neglect of pain in children, because I think it's an important part of why my title is Making Pain Matter. This is an article that I read in 1991 in the LA Times when I was an undergraduate at UCLA, and it describes the story of Jill Lawson and her young infant son, Jeffrey Lawson, who was a premature infant who had a thoracotomy performed, and at that time, standard of practice was not to use anesthesia on infant surgeries, and her son passed away a few weeks after surgery. Jill was a very brave and strong advocate and came to lots of media with her story, and her story was not about neglect of her son. Her story was actually about how is this the current standard of care for infant pain? And she brought her story to a lot of media outlets and really led to significant progress in the field. And at this time in 1991, although this had happened several years prior, the UCLA was just developing their first interdisciplinary pediatric pain program. So there was a renewed interest in pain at UCLA for young patients. And I had an opportunity to work in that program as a research assistant, which really, for me, brought me a lot of interest and passion in just understanding what are these myths about children's pain and how do we start to build evidence in this new field. There's a paper that I cite here. It's a recent Lancet commission. It's a wonderful overview of the past 40 years of pediatric pain management, and really highlighting that although there's been progress in diagnosis, assessment, and management, it has been somewhat slow over the past 40 years. And also highlighting that much of what we're doing right now, we might come to see as unwise or unacceptable or unethical in the next 40 years. So really looking at how we approach children's pain. This was a part of the Lancet Commission was to identify transformative goals. So what do we need to do to actually make a difference in the lives of children? And so 4 transformative goals were highlighted. The first one is make pain matter. I think this is really foundational because the other goals cannot occur if we can't convince health professionals, policymakers, funders, researchers, clinicians, and society that pain in children matters. The other goals are to make pain visible, make pain understood, and make pain better. So we'll concentrate a little bit today on making pain matter and really thinking about improving equity, reducing stigma, and making pain in childhood matter. So I want to highlight just that all pain is not relieved equally in the pediatric population. We've already highlighted some issues, but especially there are problems with disparities in management by race and ethnicity. This is a study conducted at Seattle Children's with my colleague Emily Law, looking at best practice emergency department management of migraine and looking at the difference between children who are from underrepresented racial and ethnic groups and whose parents have non-English language of care compared to children who do not. And what they found is that if you're a child from an underrepresented group, you had a lower chance of receiving best practice migraine treatment in the emergency department. And in this case, it was IV versus PO meds. And this was picked up by the New York Times last summer in a story here about, again, going back historically, that pain in children is often ignored, but for children of color, it's even worse. Highlight this because, again, part of taking care of all patients is learning how we can best reduce inequalities in care. So part of the myth busting that I've been really interested in over the past couple of decades is this idea that children somehow grow out of pain. And this is part of why recurrent and chronic pain in childhood was not recognized as an important entity for many years. There was this assumption that pain in childhood somehow went away. And there's been really good longitudinal studies in the past decade or so in many different populations showing that indeed many forms of chronic pain continue into adulthood. This is a nice study from Lynn Walker's group. She focuses on functional abdominal pain, and she followed children with functional abdominal pain and a well-control group that were studied in childhood, and then they did a follow-up assessment at ages 18 to 32 years. And you can see here that 35% of these patients had the exact same functional abdominal pain symptoms into adulthood. Importantly, many of them also developed other chronic pain sites. So 57% had headache and 48% had one or more sites of other forms of chronic non-abdominal pain. They also had increased risk for anxiety and depression in adulthood. So again, even if the same form of chronic pain does not continue, there's a heightened risk for other chronic pain and negative impact on health to be present in adulthood. Similarly, this is a cohort study in juvenile fibromyalgia. Similar type of design. A group of youth were studied in adolescence, and a follow-up was performed at age 24 years. You can see in this sample that 58% continued to meet diagnostic criteria for adult fibromyalgia, and there was a group that had worsening depression in adulthood.